So it's my pleasure to introduce our next speaker, Dr. Barry Zevin, uh, whose broad topic in addiction care really grows from his experience working for the Department of Public Health here in San Francisco, where he's a medical director for whole person integrated care, street medicine, shelter health, and urgent care for San Francisco. He holds other positions as well and is connected to us here at UCSF. So we're in particular very thankful for him from his busy schedule to join us. So from there, I'll stop sharing and have Barry step in. Thank you.
Thank you very much. Thank you for having me. I am a clinician and not a researcher, as will become clear. And let's see. All right.
Looks good. Thank you.
Great. We're going to talk today about a work in progress, harm reduction addiction medicine. If you look up the field of harm reduction addiction medicine, you won't find anything. You will find a lot on harm reduction and a lot on addiction medicine. And hopefully I will convince people that it's worthwhile to be talking about harm reduction addiction medicine as an entity in itself. I am speaking from the point of view of my experience providing healthcare for people experiencing homelessness, but I hope that people will feel like this is applicable as we go along. I do not have any conflicts of interest that could cause bias. This is our team. I am a primary care internist and addiction medicine specialist, but could do nothing without a team working with me. So we'll start with a case and try and stay focused on the clinical. This is a 40-year-old man with a history of necrotizing fasciitis 2 years ago. He presents for a refill of buprenorphine. He has been in care with our team for 1 year. He has received buprenorphine naloxone sublingual film strips at a higher than usual dose at 32 milligrams in split dosing. From his point of view, his problems include constant harassment by police and Department of Public Works because he's living outdoors and he cannot get a room even though others seem to get one. He has pain in the area of his major surgery from 2 years ago and also other pain that was present even before that. He expresses grief over friends and a partner who have died of overdose. He uses heroin, fentanyl, and methamphetamine, and he's concerned over the poor quality of drugs available on the street. He's extremely worried about withdrawal. And he says, I want to stop, I don't even like it anymore. And he's had many previous poor experiences with doctors and in treatment programs. His problems from the point of view, from my point of view, as a harm reduction addiction medicine medical provider, are that he's not meeting the initial goals of treatment that were mutually set. At that point, he said his goal was stopping all drug use, but by his report and by the results of urine toxicology, he's continued to use opioids and stimulants. He has intermittent follow-up with us with the frequent needs to restart buprenorphine. In fact, this is not a refill, this is a restart since he has not seen us in a month and he's been getting prescriptions on a 1 week at a time basis. He has homelessness with little chance of getting housing no matter what he changes or doesn't change, based on the extreme mismatch between our large number of people experiencing homelessness and the number of units available for permanent housing. He's at continued risk of overdose, infection, incarceration, and functional deterioration related to his continued substance use and his homelessness. So going to define some terms and try and talk about why we would talk about harm reduction addiction medicine. Harms associated with drugs and alcohol, I would classify, and I think it's important to classify in terms of, are these harms caused by the substance itself? Are they harms caused by the route of administration? Are they harms caused by our society's response to substances and substance use? There are probably other categories that we could add, but in fact, for the most part from our patient population, the harms related to route of administration and criminalization and stigmatization are perhaps more prevalent than the harms that are related to the direct effect of drugs. I can certainly talk more about that as we go along. It's something very important for us to remember in this field, that for anyone who's using substances, whether they have an addiction disorder or don't have an addiction disorder, by far the greatest harms are cigarette smoking related illnesses, alcohol related problems, and probably we put opioid overdose deaths higher on the list now than when I first made this slide, but it still is a fact that the vast majority of our substance users smoke cigarettes, have been smoking for many years, and will continue to smoke whether they change their substance use or not, and will die of a smoking-related cause. And it's also very important to understand that the use and harms related to alcohol far outpace those related to other drugs, both based on the intrinsic properties of alcohol, but also on the much higher usage of alcohol in our society. So what is harm reduction? There are several definitions. The National Harm Reduction Coalition points out that this is a practical set of strategies and ideas at reducing the negative consequences associated with drug use, and a movement for social justice with respect for the rights of people who use drugs. Harm Reduction International, which is an international organization, again points to both the practical and pragmatic aspects of this, as well as the social justice and ethical aspects of respecting people as human beings, respecting people's autonomy, whether they are using substances or not. Shifting gears for a moment, addiction medicine is a medical subspecialty formally recognized since 1990, in existence since before that, concerned with prevention, evaluation, diagnosis, treatment, and recovery of persons with the disease of addiction and substance-related health conditions. And they mention both licit and illicit drugs and substances. In the field of addiction medicine, we are looking at biopsychosocial spiritual models. I think many of us are familiar with the construct of biopsychosocial. I first heard the term biopsychosocial spiritual at addiction medicine conferences. And I think that is really worth thinking about as, and I'll talk a little bit more about the spiritual aspects as we go along. Well, what is addiction treatment? NIDA has, I think, a very illuminating, both for what's there and what's not there, definition of addiction treatment on their website. Addiction treatment is intended to help addicted individuals stop compulsive drug seeking and use. There's a variety of different kinds of treatment. It's noted that addiction is a chronic disorder and characterized by occasional relapses, and therefore treatment may be a long-term process involving multiple interventions and regular monitoring. I think it's important to note that there's nothing about reducing harms, and there's not a whole lot about that's patient-centered right there in thinking about addiction treatment. Let's talk about homelessness for a moment. I like this quote. Every talk has to have a quote from Maya Angelou. "The ache for home lives in all of us, the place where we can go as we are and not be questioned." The term we use is homelessness. We try to really focus on the fact that homelessness is a state, not a trait. And we use person-centered language, and we're really trying to avoid talking about homeless people, probably in the same way that we ought to avoid talking about addicted people, and prefer to talk about a person experiencing homelessness. So I as a primary care provider, as a specialist in areas where we have far more not known than known, I rarely get a chance to be dogmatic, but I'm going to be dogmatic about homelessness. Homelessness is a result of poverty. Poverty is a result of disadvantage, discrimination, and disability. Homelessness is a result of lack of affordable housing. Lack of affordable housing is a result of policy, governmental policy. I want to go back to disadvantage, discrimination, and disability for a moment, because if you ask the average person, what is the cause of homelessness, they're very likely, as many people have told me, to say homelessness it's mainly because of mental illness and addiction. And certainly many people with mental health disorders and addiction disorders are disabled and have a history that's marked by disadvantage and discrimination, putting them at very high risk of poverty and homelessness. I would certainly add chronic pain to that list of disability and causes of poverty. As I think about how I work with our homeless population, I think about barriers to treatment. And we literally, as we start new projects, as we work in new areas, ask and try to list what will be the barriers to this person being able to receive the best possible treatments. This is a general list of barriers that we've mainly put together in thinking about how to deliver low barrier medications for addiction treatment, specifically buprenorphine, in a low barrier way. One of the things that I really like about this is thinking about challenges on the patient side, and then challenges related to perceptions on the provider side. And something that I think is very important as we think about what would a model of harm reduction addiction medicine look like is patients' perception of treatment and care providers as they just want to control you. And I've heard this from numerous patients. And on the provider side, the perception that they are out of control. Again, something I have heard from numerous medical providers and addiction treatment providers. And I think that is a
I think we've lost the audio for Dr. Zevin. Just wait 1 minute here.
See.
Sorry, we're just waiting a moment. I think he had some challenge on his side.
Am I back?
Yes, thank you.
Excellent. Apologies. Don't know what happened there.
No trouble.
Let's continue our case. A 40-year-old man with a history of necrotizing fasciitis. Has this patient failed treatment? Has the treatment system failed the patient? Or is our approach successful? On the one hand, he continues to use methamphetamine and opioids most days. He continues homeless, estranged from family, disconnected from mainstream society in almost every way. He has frustrating interactions at clinic because he is sometimes early and often late for refills and has not taken buprenorphine. He's frustrated that the provider keeps talking about problems of diversion and keeps talking about the need to intensify treatment. And he continues to have severe pain.
Barry, you want to go to full screen? Thank you.
Got it. On the other hand, he has completed a course of hepatitis C treatment and is cured. He has had no hospitalizations or ER visits since entering our care. He has a positive UTOX for buprenorphine every time he reported taking it and was tested. And he often takes buprenorphine obtained illicitly if he can't get into the clinic. He consistently reports less use than before entering treatment. He's had no episodes of severe withdrawal, no recent overdose, no skin and soft tissue infection, no HIV, no HCV reinfection. He looks better and is functioning better. He's reversed many overdoses on the street and always carries naloxone. He has a vibrant social network and community on the street, and he's extremely grateful for treatment received. How do we think about and measure success in our treatment? Conventionally, we think about the term recovery, and I'll talk more about that in a moment. Specifically, we talk about abstinence and relapse, and completing the treatment program, and continuous retention and care. The evolving thoughts are reduction in use, functional assessments, and the effects on personal, social, and emotional states. And lastly, I'd say, although we haven't looked at this in terms of treatment well, harm reduction measures, thinking about a person who sets their goals and mutually set goals, people living and survival, and avoidance of defined harms. I want to point out that we use the term recovery a lot, and the same word has many meanings and paradigms. I've listed just a few here. And I think that as we think about the term recovery, we really need to be very sure of what we mean. And if we're talking to another person, that we're understanding the same thing. I want just to mention harm reduction psychotherapy, which is a well-defined set of interventions in the mental health field, working with people with substance use disorders. They're often concerned with existential issues, although uncomfortable with the term spiritual. And I think we can use the model of harm reduction psychotherapy getting toward our model of harm reduction addiction medicine. So addiction medicine has tried to reduce moral model of addiction by focusing on biological elements. I think a very worthy activity. It's focused on spiritual elements of treatment with support and supporting 12-step recovery model. And the question, why do you use, is not a typical question or concern in most of the way we typically think about addiction medicine. Harm reduction is much more focused on concerns for autonomy, dignity, agency, and social justice. It's centered on the opinions, needs, and desires of individuals who use substances and the community of users. And the question, why do you use, is a legitimate and useful question. And I hope that we can combine the strengths of these two areas and avoid the problems. So getting back to our harms, what are some of the ways that we can approach these common harms using harm reduction addiction medicine? In terms of the direct neurotoxicity and other biological toxicity, certainly in terms of overdose, making naloxone and information on overdose prevention available. Invent better and safer drugs, or at least legalize the ones we have so that they are not needing to be used in ways that are as dangerous. I'd ask the question, and I've asked the question a lot, and I rarely get to ask the question with basic science people, but I'd love to ask the question, are highly rewarding drugs possible with lower risk of addiction? People who use drugs want a particular experience as they are using a particular mind-altering experience, but they certainly don't ever sign up for, yes, I want to become dependent and I want to have the illness of addiction related to having that experience, perhaps of euphoria or of avoiding feelings of dysphoria. And how can we engineer better drug using experiences? And certainly having accessible and acceptable evidence-based treatment that would actually be effective. Relating to harms due to route of administration, education and structural change is needed. Safer consumption spaces are, I think, successful in many areas and would be successful in America. And an example of this that has not been driven by our medical interventions, but in San Francisco, many people have stopped injecting and are using a smoked or vaporized form of using fentanyl, thus avoiding the problems related to injection. Ultimately, we need to reduce the harms related to criminalization and stigmatization, decriminalize, legalize, regulate, change values of our society, and restore meaning to people's lives. That spiritual aspect of care comes back. And perhaps of all the things that our patient in the case told us, the fact that he's active on the street and has been able to reverse many overdoses is certainly what feels like the most likely thing that will help him achieve recovery, however we define that, in his life. What is the future of harm reduction addiction medicine? There's continued limitations due to the slow penetration of support for harm reduction paradigms. For many years, the government did not even accept that in any grant whatsoever that went to the federal government. If the words harm reduction were in it, it was returned. Harm reduction approaches to tobacco, smoking, and alcohol will probably prevail without calling it that. Continued limitations on the funding for promising areas of research are a limit, but we certainly can encourage that research. Certainly, it's more likely to be accepted in the areas of the severely affected and underserved. It makes sense to most of us who are homeless health providers. And we're probably, because I think this has so much validity, we'll probably continue these approaches and probably call it something else, which is fine, as long as we save the meaning. So thank you to my colleagues in the Department of Public Health, Street Medicine, and Shelter Health, and our many partners, and to our patients who we learn from every day. Sorry for the problem in the audio and video. Are there questions?
Thank you, Barry, very much. You can stop sharing.
Got it.
That's a deep dive into an area of clinical medicine. A few of us have, hang on, right on time. That few of us have had direct contact at that depth. I have a couple follow-ups that are broad. And that would be this point you brought up between addressing, of course, the complete biopsychosocial spiritual model. I mean, so much of the research is driven around drug discovery and new medications, safer meds, as you've listed, and I saw that as sort of your gap analysis. What's your thoughts? Do you think there'll come a time, or is it even a goal, to develop essentially an anti-addiction medication? Do you think that will actually solve the problem?
I'm tempted to say, and I guess I'll say that I think that will solve the problem in the same way that I say to solve the problem of, and many people say, to solve the problem of addiction, we're going to need to drastically reduce the incidence of adverse childhood experiences. We're going to have to drastically reduce the effects of widespread racism and other discrimination in our society. We're going to have to make major changes in how we think about people who have disabling mental health conditions. No, the miracle drugs for treatment of addiction are not going to cure addiction. On the other hand, they will go a long way to reducing the harms related to addiction and allow us to continue to focus on what the absolute root causes of those harms are, which are a combination of susceptibility in the human brain for this, and the sort of profound failings in our society in which we treat people who have less advantages.
Sure. I think Alan has maybe a direct question, since he has control of this microphone. So go ahead, Alan.
Well, I tried to go through Q&A, but I can't type anything into it.
Yeah, nobody can.
Oh, that's a problem. Okay.
Yeah. Anyway,
Yeah.
Thank you very much. I actually have two somewhat, well, they're obviously relevant, related questions. One is, you didn't address the actual availability of the drugs. My understanding is about 50% of the opioid misuse disorder problem, in opioids specifically in the States, is prescription-based. The other half is drugs coming in from abroad, fentanyl in particular, through Canada. So obviously, if you reduce the supply, I would think it would help. The other question is more in talking to friends who work in the city. My understanding is there's about, $500 million that is actually spent out of the city budget for homeless, but ineffectually. And I'm curious whether you agree with that, or that number is made up, or where is the problem in the way the money is dispersed?
Sure. I'm going to speak to the second question first, where I have an area of expertise, and then I will try to speak a little bit to the first question. So indeed, the city of San Francisco spends, if you add it all up, $300 or $400 million on homelessness, but that's a bit of a misnomer. The vast majority of that funding is keeping formerly homeless people housed, which, as you might imagine, keeping people who are destitute in housing and maintaining that housing is and obtaining new housing for more people is an incredibly expensive, incredibly arduous procedure, and never ends. The people who we see have the same, once they're housed, have the same set of problems they had before they were housed, and will continue to need that subsidization of their housing until such day as the federal government truly decides that they wish to end homelessness. There are much smaller amounts that are used in various treatment for people experiencing homelessness, outreach to people experiencing homelessness, other things. I would never say that we don't have a ways to go to make that more efficient and more effective, specifically on the treatment of homeless people with addiction end. I think we do a poor job. But I think that overall, San Francisco does an excellent job, and it's really important to understand that where the money goes. As to the other question, does interdiction help? Could we stop?
Sorry to interrupt. Why don't we hold the answer to the second part of that as part of our break in chat? We'll have to be there to the next speaker. If we could hang on to the response to that one, we'll have some time for all speakers, but also Barry to get back to that one. Thank you.